Good day, ladies and gentlemen, and welcome to the Reducing Risks for Surgical Site Infections in the 21st Century, New Recommendations from Evidence-Based Guidelines conference call hosted by Dr. Liza Ovington. My name is Sue and I'm your event manager. During the presentation, your lines will remain on listen only. If you require assistance at any time, please key *0 on your telephone and a coordinator will be happy to assist you. I would like to advise all parties that this conference is being recorded for replay purposes. And now I'd like to hand the call over to Sarah Smith, U.S. Marketing for Ethicon. Please go ahead.
Thank you very much, Sue. Welcome, everyone. Thank you for joining us today. It is with great pleasure that I introduce to you Dr. Liza Ovington, Medical Director of Wound Healing and Infection Prevention at Johnson & Johnson Medical Devices. Dr. Ovington holds a PhD in Organic Chemistry from Duke University and maintains adjunct faculty positions at the University of Miami and the University of Pittsburgh. She is board certified in wound care by the American Board of Wound Management and is a fellow of the American College of Clinical Wound Specialists. Without further ado, I will turn it over to Dr. Ovington for today's presentation on reducing risk for surgical site infection in the 21st century, new recommendations from evidence-based guidelines. Thank you, Dr. Ovington.
Thank you, Sarah. It's my pleasure. I'd like to welcome everyone to the WebEx today. And for the next 45 minutes or so, I really want to have a great conversation about where we stand in the fight against surgical site infection by providing a high-level overview of some recently published guidelines for evidence-based approaches to reducing the risk for surgical site infection. As a surgical device company, Ethicon has a great interest in this type of evidence-based information, and we're very happy to discuss and share this with you. So specifically, what we'll be talking about is the data from 3 recent evidence-based guidelines, particularly the World Health Organization's guideline from 2016 that came out last fall, another evidence-based guideline from the American College of Surgeons and Surgical Infection Society, their 2016 guideline update that also came out in the fall of 2016 and then was published early this year. And then additionally, the long-awaited update to the Center for Disease Control guideline on infection prevention. So I want to kind of give a high-level overview of those evidence-based guidelines and how they were put together, what the recommendations are, talk a little bit about what's new, what's changed, and what's remained the same. So without further ado, we will get into it and first discuss the WHO 2016 Global Guidelines. So the WHO guideline, this was actually the inaugural guideline for the World Health Organization with respect to surgical site infection prevention. And it was specifically positioned as a global guideline, both in the title and its intent. In its introduction, it calls out 3 specific reasons that they undertook this, what you'll see is a very robust process to examine the evidence for practices to reduce risk for surgical site infection. They stated that, in their view, there was a previous absence of an international guidance document. And it's important to remember that at the time of the WHO guideline and when they were thinking about it and executing it, the CDC guideline had not been updated at that time. They also noted that they felt there were inconsistencies in the interpretation of evidence and the strength of recommendations in the individual national guidelines that they were aware of, and they wanted to specifically make their guideline valid for any country, both high-income and low to middle-income countries. They wanted to make it suitable for local adaptations and, clearly take into account the strength of the scientific evidence, as well as the cost and the resource implications of implementing some of these guidelines, as well as patient values and preferences. So I will tell you that it's a very hefty document. I think it would come in as a heavyweight. It's 186 pages in length. That sounds like a lot. It is a lot. I can tell you it's a very informative and enjoyable read, and it's very well partitioned, so you don't necessarily have to read 186 pages to get everything out of it. There are various summaries, but if you really want to drill down into content, there's a lot there to take in. It is a fully downloadable document. You can access it at the WHO website, and I've provided that link within the slide deck. And I'll tell you that in addition to the document itself, there are a number of web appendices. So I'll talk about those a little bit more when we get into the nuts and bolts of the process that was followed for developing the guideline. But their objectives in developing this guideline, in addition to what's previously stated, is they really talked about wanting to improve the quality of care and the outcome for patients undergoing surgery worldwide. It was the first SSI prevention guideline for the WHO, and again, a very robust process that they followed. So to get into that a little bit, the guideline process, they followed the most recent norms of evidence-based practice, and they were set out initially to identify and formulate what were the key research questions that they wanted to get answers to. What were the priority topics for SSI prevention according to the PICO process? And the PICO process is well known to those in evidence-based medicine as defining your question as well as your search strategy by identifying the population you're interested in, the specific intervention that you want to uncover evidence about, what it might be compared to, and what are the outcomes you're interested in. It just makes your systematic review of the literature from which you're going to glean the data much more robust and thorough. After designing their research questions and the search strategies, they actually performed targeted systematic literature reviews for all of the questions. In total, they did 27 different systematic literature reviews and meta-analyses of the data. Now, what this means, and I think this is an important distinction for the WHO guideline versus other guidelines, is that they didn't just kind of look at the evidence, read it, and then make an opinion or a narrative assessment of what the evidence said. They actually statistically analyzed. They did basically new research and meta-analyzing the data that they had collected. So these 27 different meta-analyses are what led to the statements and the recommendations that they make. And what I want to refer you to is that on their website, in addition to the 186-page guideline itself, each and every one of these systematic literature reviews are available as a web appendix. And it appears from the website and also from what I've seen in the peer-reviewed literature that they have a cadence and they're publishing their meta-analyses in the peer-reviewed medical literature, which is a great thing because it's a very august body of experts that were on the WHO panel that performed these analyses and came up with the final recommendations. But they're also subjecting their process to peer review in the medical literature as well as full transparency about how and what they did. Importantly, and as they have mentioned, they graded the quality of the evidence, and they used the grade methodology, the grading of recommendations, assessment, development, and evaluation. So they used a very well-accepted process for grading their recommendations and the evidence behind them. Now, in a nutshell, there were 20 international experts on the panel performing the work. As I said, they actually did 27 different systematic literature reviews and meta-analyses, and ultimately came out with 29 unique recommendations. They categorized their recommendations into two buckets of things that you would do preoperatively. There were 13 recommendations for preoperatively, and then 16 different recommendations for practices that would be instituted in the intraoperative or postoperative periods. So in addition to the ratings, the recommendations themselves, any individual recommendation is either rated as a strong recommendation, of which there were 9 of those out of the total of 29. The other 20 were rated as conditional. And that recommendation rating as strong or conditional really tracks back to the robustness of the evidence that led to that recommendation. They separately evaluated the evidence for each recommendation as either very low quality, moderate quality, or strong quality evidence. And the evidence quality really has to do with the study design. You know, was it a randomized controlled trial? Was it appropriately blinded, if that was possible? Was it appropriately powered for the outcome? So it had a lot to do with study design. Now, what I'd like to do is kind of take you on a brief tour of those 29 recommendations. So that's going to sound like a lot to go through, and I didn't want that to become too wordy or too static. So I actually tried to group the recommendations into the do's and don'ts, because some recommendations were about what you should do, but there were also recommendations that were worded as what you shouldn't do based on the evidence. So I would refer you to the actual guideline document for the exact wordings, because I've taken a bit of a liberty in kind of condensing them down to something that we can cover relatively quickly, and also into these buckets of do's and don'ts. But I'm going to stick with their categorizations of preoperative recommendations. So preoperatively, remember there were 13 recommendations overall, and 9 of those were about things to do. I'll note for you that on the slide where I put something in bold, that indicates that it was rated as a strong recommendation. So that typically means that the evidence supporting that recommendation is of a higher quality or a higher amount of evidence, more studies versus the recommendations that are not in bold, which are rated as conditional in strength. So for the do's preoperatively, and I think a lot of these will make inherent sense, and not a lot of them are necessarily new to you, but it's updated with the most current evidence. They do want you to consider multi-nutrient support for patients who are clinically underweight prior to surgery. They talk about using soap for patient bathing or showering, and that soap can be either plain or antimicrobial, so they didn't see a lot of evidence for a strong recommendation for antimicrobial over plain soap, so they recommended either. There was a strong recommendation for the use of intranasal mupirocin for known Staph aureus carriers in cardiothoracic surgery and orthopedic surgery specifically. That's where the data was clustered. So the use of 2% mupirocin for known carriers was a strong recommendation, and then a conditional recommendation to consider that 2% mupirocin for other known carriers, in other words, outside of CT and ortho. There was a recommendation to use oral antibiotics in combination with mechanical bowel prep for elective colorectal patients. There have been some controversy in the medical literature about whether mechanical bowel prep alone was effective, so their recommendation is to use these two together, oral antibiotics and mechanical prep. A recommendation to obviously administer surgical antimicrobial prophylaxis or antibiotic prophylaxis when indicated based on the surgery type, i.e. clean, contaminated, et cetera, and to administer that prophylaxis at least 2 hours before the incision. And then a couple of recommendations around prep for the surgical team to use antimicrobial soap and water or alcoholic-based hand rubs for hand prep, and for patients to use preferentially alcoholic chlorhexidine gluconate solutions for skin prep, again, according to the evidence. So those are the preoperative do's. Now, there remain 4 preoperative don'ts. So the WHO had recommendations to not discontinue immunosuppressive meds before surgery in patients who were on those medications. Do not use mechanical bowel prep alone. So that one, they kind of hit it twice. They hit it with a do use mechanical bowel prep with oral antibiotics and do not use it alone. So that was one that kind of got a double hit. And then, not surprisingly, again, this is not a new recommendation, but it's now a strong recommendation. Do not remove hair unless absolutely necessary, and if you're going to do it, use clippers. Don't use shaving. And then don't use antimicrobial skin sealants after skin prep. They have found no evidence to date that those made a clinically significant difference beyond the standard skin prep with the alcoholic CHG solutions. Now, moving on to the intraoperative and postoperative recommendations. Well, again, there were 16 of those, and 6 of them were don'ts. So I'm going to continue on the don't track for a moment. We'll do the don'ts before the do's. Intraoperatively and postoperatively, they say do not use plastic adhesive incise drapes, either with or without antimicrobials. Again, no significant level of evidence to date that these are doing anything that leads to a noticeable clinical benefit. Do not perform antibiotic incisional wound irrigation, so don't irrigate your surgical incisions with antibiotic solutions. Don't use total laminar airflow for total arthroplasty. Again, not enough data at this point to make that recommendation. In fact, when there's a do not recommendation, it almost says there's been enough data to say that it doesn't help, not that it's an unresolved issue. Do not continue prophylactic antibiotics because you're placing a wound drain. That's not an indication for that. And don't use advanced wound dressings post-operatively. So I know there's a lot of information and a lot of work going on with advanced wound dressings with different functions, whether they're antimicrobial or moisture vapor transmission, et cetera, but they found no evidence to date that these advanced wound dressings are making a difference with regard to surgical site infection when used on closed incisions postoperatively. And then a strong recommendation for not prolonging antibiotic prophylaxis beyond the completion of the operation. So those are the don'ts. And again, each one of these recommendations is backed up by a systematic literature review, and those individual reviews and meta-analyses are also available on the website and slowly being published in the peer-reviewed medical literature. Now, closing out our survey of the WHO guideline recommendations for the do's for the intraoperative or postoperative period, they talk about administering 80% inspired oxygen, both intraoperatively and for 2 to 6 hours post-op. That this does make a difference, and this is the only strong do recommendation with regard to surgical site infection. Do use patient warming devices for normothermia. And again, they call out, and if you read the full guideline, and this one they call out that this can be done with, more sophisticated systems like the patient warming systems that we may be familiar with in ORs in the United States, but it can even be carried out with blankets in low to middle income countries if that technology is not available or affordable, but it is important to maintain patient normothermia by whatever means is available. Do use goal-directed fluid therapy to maintain normovolemia. Do carry out intensive perioperative glucose control for both diabetic and non-diabetic patients. Use sterile, disposable, or reusable sterile drapes and gowns. There were 2 consider recommendations. Consider using wound protectors in clean, contaminated, and dirty abdominal surgeries. So again, this is an area where maybe the data wasn't quite robust enough for a full do, but they do say consider using wound protectors. And consider incisional PVP irrigation before closure in clean contaminated cases. So remember, there was a don't about antibiotic irrigation, but there was a consider for incisional PVP irrigation in certain cases. And then some new technologies. And these are some of the really new recommendations that we haven't necessarily seen before in prior evidence-based guidelines. There is a recommendation to use negative pressure wound therapy on high-risk incisions, defined as abdominal or cardiovascular cases, but not in ortho or trauma. And again, to drill down as to why they called out certain types of surgeries and not the others, it's very beneficial to dive into those systematic literature reviews and look at the evidence behind it, which we don't necessarily have the time to do today, but I'm telling you it's very well described in the web appendices. And then a second new recommendation is do use triclosan-coated sutures for wound closure independent of surgery type. This is the first time we've seen a recommendation about the choice of your wound closure device having an impact in surgical site infection. And then the final recommendation in the do's for intraoperative and postoperative is do remove wound drains when clinically indicated. So again, 1 strong do recommendation out of the 10s, 2 kind of new topic areas with negative pressure wound therapy and triclosan-coated sutures. And that's really the survey of the recommendations themselves. I want to remind you, as mentioned, the guideline exists. It can be downloaded as a very robust document, but they also published the full guideline content as a series of 2 papers in the Lancet Infectious Diseases. And these peer-reviewed publications came out almost simultaneously with the guideline dropping on the website in November of last year. And at the time that they dropped, these were open access. I don't know how long that'll last, but I've provided the links in case you're not a subscriber that they may still be open access for the peer-reviewed publication. which is going to be a more user-friendly, perhaps, version of the recommendations with a summary of the methodology and the evidence behind them. But again, the full guideline has a lot more information, and the appendices will provide even more information than the peer-reviewed articles if you want to dig into the individual data sources. Additionally, as I mentioned, for all those individual systematic literature reviews, they are publishing. It looks like they're planning to publish and have published in the peer-reviewed medical literature those individual meta-analyses. So I want to call to your attention that they have an associated peer-reviewed publication of the meta-analysis that led to the triclosan-coated sutures recommendation that came out in the fall in European Journal of Clinical and Microbiological Infectious Diseases. So that was the article by Wu. So again, with regard to the WHO guideline, they had a very robust process. They did de novo kind of new analysis of the accumulated data by performing those systematic literature reviews with meta-analysis. So they took all that individual data and statistically combined it to come up with their meta-analyses results that led to their recommendations. And they're putting these into the peer-reviewed publication, into the peer-reviewed literature. So that is kind of the quick overview of the WHO guidelines. I want to move on and talk to you about the second guideline on our list today, the American College of Surgeons and the Surgical Infection Society Guidelines 2016 update. So this was another evidence-based guideline that was presented in mid-year last year and accepted for publication in the fall, published online in October last year, and then in print in January of this year. So it was published as a special article in the Journal of the American College of Surgeons. So some differences here with regard to the process involved. Again, their stated objectives, and at the time probably that they were doing this work, the WHO hadn't really hit yet, and the CDC guideline had not yet been updated. So their stated objectives from this group was to update earlier guidelines, specifically 3 earlier guidelines with current literature, and to summarize the relevant topics. And the 3 guidelines that they referred to that they were seeking to update were the 2014 SHEA IDSA guidelines on strategies to prevent surgical site infections in acute care hospitals, the American the AHSP, American Health System Pharmacists Guidelines for Antimicrobial Prophylaxis and Surgery, and then the 1999 CDC Guideline itself, which, itself was separately published in Infection Control and Hospital Epidemiology. So they kind of took those guidelines as a starting point and looked to update them with more recent literature. Now, the process they used was somewhat different. So it wasn't quite as robust as what the WHO did and what the CDC will do, as we'll talk about next. They did do a literature review. They searched in one database. They searched in the Medline database accessed through PubMed. And again, they were just looking for recent literature to address knowledge gaps in those 3 previously published guidelines. So what they did was they basically identified the literature, they read it, and they summarized it in a narrative review. The difference here is that they didn't do any meta-analysis. They didn't kind of combine the data to look for significant effects that might not have showed up in the individual data. So it was a narrative review without meta-analysis. Again, just a different type of review and process. So overall, at the end of their exercise, they came out with 22 recommendations, which they categorized into pre-hospital recommendations, of which there were 5, 15 in-hospital recommendations, and 2 post-discharge recommendations. Now, they didn't provide any ratings of the recommendations as strong or conditional, and they didn't really talk about the strength of the evidence behind them. But because it is another recent guideline, we're going to go through these recommendations. And again, I've taken a bit of a liberty, again, in trying to present them in a concise fashion. And I've tried to translate them similarly into do's and don'ts where possible. And I do refer you to the original publication for the exact wordings of their recommendations. So for the pre-hospital recommendations, there were 5. And again, none of these will be surprising, and they will sound familiar, having gone through the WHO recommendations. They do recommend preoperative bathing but they caution that it should be done as part of an overall bundle or protocol, because if you only do preoperative bathing without other aspects of a decolonization bundle, they said that it wasn't shown to decrease SSI. Not surprisingly, they talked about smoking cessation. They did recommend trying to institute cessation 4 to 6 weeks before surgery for all current smokers. Some other guidelines recommend 30 days, but they came up with the 4 to 6 weeks. They did encourage glucose control for all diabetics, noting that improved hemoglobin A1C is not shown to decrease SSI risk, but they do encourage tight glucose control immediately preoperatively for the diabetics. They didn't speak to the non-diabetic patients. They said with regard to MRSA screening, they were a little equivocal on that. Depends on the baseline SSI and MRSA rates in your facility. And then they did talk about the combination of mechanical and oral antibiotics for bowel prep and elective colectomy. So those are the pre-hospital recommendations. With regard to the hospital recommendations, of which there were 15, we're going to look at 8 of them on this slide. They do recommend glucose control and specifically identified some target levels between 110 and 150 in all patients. And again, familiar with hair removal, don't do it unless it's absolutely necessary, and clippers if so. Recommending alcoholic skin preps, CHG if you don't have alcoholics in any form of CHG skin prep. Similar with the surgical hand prep, either traditional or the alcohol-based hand rubs. Didn't really speak about surgical attire. They said there was limited evidence for specific recommendations. And antibiotic prophylaxis, one of the things that's interesting about this guideline is they do mention weight adjustment of the dosing, which is not really mentioned in the other guidelines. Probably because there wasn't an abundance of literature there yet, but there are some strong opinions on that. They do recommend intraoperative normothermia, and they say do use wound protectors, not just consider using wound protectors, but do use them in open abdominal surgeries. Continuing with the hospital recommendations, they also include a recommendation for the use of triclosan-coated antibacterial sutures. They limit this to clean and clean-contaminated abdominal cases when available. They recommend double gloving and changing before colorectal procedures, using new instruments for colorectal closure. And specifically with regard to wound closure, aside from the recommendation for antibacterial sutures, they talk about purse string closure for stomocytes. They didn't really enter the fray on topical antibiotics. They said there was insufficient evidence to say anything about that. They concurred with the WHO on using 80% inspired oxygen immediately post-op, and then they also had a limited recommendation for the use of the negative pressure wound therapy to reduce SSI in abdominal and groin incisions. And then finally, for their group of recommendations, there were 2 post-discharge recommendations, or actually lack of recommendations, with regard to a specific protocol for wound care post-operatively or specific methods for SSI surveillance. So they said we didn't really have enough evidence to make a recommendation there. So again, a slightly different, more qualitative guideline as opposed to the more robust meta-analytic statistical review that was carried out by the WHO. So we have kind of maybe 2 extremes there. And then finally, we'll move on to a discussion of the long-awaited update to the CDC guidelines for SSI prevention. The prior guideline was published in 1999, and it's now being updated for the first time. Its stated importance is that approximately half of the surgical site infections are deemed preventable if you're using evidence-based strategies. So they have been on a long journey to update their kind of seminal guideline. The objectives of the guideline were to provide new and updated evidence. And one thing that I want to make sure that we note, if you're reading the document and you may say, well, they're silent on a few things, like they're not talking about hair removal, they're not talking about surgical skin prep or antisepsis for the surgical team. They're not talking about it because they made a conscious decision not to reevaluate recommendations that they consider to have strong evidence, both beginning and to still have strong evidence. They said that they specifically said, we're not reevaluating recommendations in the CDC guideline that are now considered to be accepted practice. And these recommendations, as I kind of alluded to, fall into the categories of, patient prep regarding hair removal, smoking cessation, hand and forearms antisepsis for the surgical team, surgical attire and drapes, sterile and surgical technique, et cetera. And similar to the CDC, you have the peer-reviewed publication as well as a significant amount of content online. And the links to this online content are within the electronic version of the actual document that I showed you. So in this publication, there will be electronic links to the online content on the CDC website. And again, as I mentioned, there's 600 pages of this that are available for download, and I have provided a link as well in the slide deck. And just in case you're interested and you want to take a look at those recommendations from 1999 that were not updated because they're considered accepted practice, they are on page 41 of the 600 pages. It's in section 5, in case you're interested in that way. But again, I would highly encourage you to take advantage of accessing that online content while it's available and downloading it while it's free. Their guideline process, again, is more similar to the WHO process. It was a targeted systematic review. They conducted their review in multiple medical databases, both Medline, Embase, and the nursing CNAL, as well as specific searches on the Cochrane Library site. And they covered the time period from 1998, so just before the last guideline, the kind of contiguous with the evidence from the last guideline that was published in 1999. They said we're going to look at the evidence since then from 98 to actually April of 2014. So it took a while to crunch all that data to get all the appropriate reviews and then finally get to publication. And then they also used a robust process. They were providing links between the evidence and the recommendations, so they did provide the strength of recommendation and quality of evidence rating similar to the WHO, and they also used a modified grade approach in terms of their evaluation. So again, robust evidence-based methods were used. Now, from the snapshot view, there were 42 different statements, even excluding the ones that weren't updated, 42 statements that were considered in terms of looking for evidence to support them. What kind of struck me is that of those 42, 25 resulted in a no recommendation or an unresolved issue. In other words, they just didn't have enough evidence to come out with a statement one way or the other about 25 of the 42 statements. But they did result in 25 actual recommendations. And as mentioned, they rated their recommendations as 1A, 1B, 1C, which are all strong recommendations with variable levels of evidence quality, or they rated the recommendations as level 2, which was considered a weaker recommendation as opposed to the strong ones that were supported by any quality of evidence, suggesting that future data could potentially change the direction of the recommendation. Now, again, we'll take a brief overview of these recommendations, and again, I'm going to refer you to the actual document for the exact wordings. Actually, no, in this case, I did use the exact wordings, but I tried to bold them and, again, summarize them into the do's and the don'ts. That's just a simple bucket system that helps me kind of keep some of this in my head. So just as a reminder, and I've already referred you to page 41 of the 600-page document where you can look at all these, but these are the categories of recommendations that were not revisited because they were considered accepted practice at this point. And in terms of the do's, here are some of the do recommendations of those 17. So they said, do recommend administering preoperative antimicrobial agents when indicated, and do it. They didn't come out with a specific time, but they said time it so that the concentration of the agents is established at the time of incision. So they didn't really come out and say 2 hours before the way that the WHO did. They did recommend administering the appropriate antimicrobial agents before skin incision in cesarean procedures. Again, I've included the evidence ratings for you here as well. And again, the third time around now, we do see this new recommendation for considering the use of triclosan-coated sutures for the prevention of SSI. And this to me really stands out because in no SSI prevention guideline, evidence-based guideline to date, has the topic of your choice for surgical wound closure been considered as an evidence-based practice that could have an impact on the risk. But all three of these recommendations now contain a recommendation for the use of trucks and coated sutures. They do talk about the perioperative glycemic control and give some guidance to target levels. So they're basically saying, keep it below 200 in all patients. Not as specific as what the ACS said, but again, the ACS was looking at individual studies, and both WHO and CDC were looking at an aggregate meta-analytic result of the evidence as opposed to a narrative review. More do's from the CDC. They come out in favor of maintaining perioperative normothermia, not necessarily recommending the method used to do that, but to maintain it. They do come out talking about administering increased inspired oxygen during and after surgery and maintaining perioperative normothermia and normovolemia. They are advising showering or bathing at least the night before the operative day for the patients, again, with soap or antimicrobial or non-antimicrobial, and then using alcohol-based skin preps unless they're contraindicated in the patient. With regard to their don'ts, so they had a number of don't recommendations. And the first one that I've mentioned here, they're saying do not administer additional prophylactic antimicrobial doses after surgical wound closure, even in the presence of a drain. I've colored this one blue because they actually say this in different ways 3 different times. So it kind of brings those 17 recommendations down to 15 because you're going to see this one come up again, worded slightly differently. They come out and say do not apply antimicrobial agents to the surgical incision. They didn't find any evidence for benefit of the autologous platelet-rich plasma, which is kind of a relatively new intervention, at least since 1999. They said that using microbial sealants is not necessary, again, echoing what ACS and WHO say, and again, plastic adhesive drapes with or without antimicrobial properties is not necessary. So we're seeing agreement between these recommendations from the different groups. More don'ts. They say that you can consider intraoperative irrigation with iodophores, similar to what the previous guidelines have said, but it's not necessary. Lavage is not necessary in contaminated or dirty abdominal procedures. Don't withhold transfusion as a means of preventing SSI. And here again, that don't administer additional antimicrobial prophylaxis after the surgical incision is closed and clean contaminated procedures. So it comes up again. So that's a whirlwind review of the recommendations from the guidelines, a little bit of information about the methodology behind how the guidelines were drafted and their intents and the process that they followed. Again, much more detail for the 2 that used robust meta-analytic techniques, a lot of transparency about what information was included and how it was analyzed through separate publication or through online content. And with regard to the similarities, I think you may have noticed, just in the brief overview I did, that, these are just some examples. With regard to patient bathing, all the guidelines talk about patient bathing and said, you can use plain or antimicrobial soap. The ACS kind of went a step and said, do it as part of a bundle, which was not specifically mentioned by the WHO or CDC. Everybody fell in line with glucose control. There were some slight differences about target levels. The WHO said, yeah, I don't think there's a lot of data to come out and recommend a target level. But CDC did recommend a target level, and so did ACS, again, reminding you that their procedure is a little less robust in terms of aggregate data. Everybody said skin prep with alcoholic solutions. The WHO went so far as to say the preference is alcoholic CHG. Everybody talked about well, not everybody. The WHO and the ACS talked about oral antibiotic and mechanical bowel prep. I think CDC might have considered that one of their, I'll have to check, might have considered that one of their accepted practice already. And then everybody had something to say, but different levels of detail about surgical antibiotic prophylaxis. So Across the guidelines, they're covering the same topics, which is no real surprise to us. And depending on the methodology they use, they may be more or less specific about the nature of the wording of their recommendation with regard to very specific levels or time periods, et cetera. But if you look across the guidelines, you don't see a lot of surprises, except what I think is truly new is that for the first time in all three guidelines, the choice of a wound closure device is considered and recommended as an evidence-based intervention within an overall bundle for reducing risk of SSI. All three of the guidelines mention the use of antibacterial sutures, specifically triclosan-coated sutures, as part of their overall group of recommendations. They also mention, as another new therapy, the use of negative pressure wound therapy in certain cases. And I think that it's pretty exciting now that we're seeing not only three different evidence-based guidelines. We can be comforted by the fact that they're not in disagreement with each other, which really attests to the evidence-based process. And they're all kind of noticing and talking about the same new things and strengthening, in some cases, with more or less specificity, recommendations that we are familiar with. So with regard to some of the wording, just as an example of how the wording might differ slightly, I'll talk about the triclosan-coated suture recommendations. From the WHO, the wording is, I think, noticeably different and notable in the sense that the panel says they suggest the use of triclosan-coated sutures for the purpose of reducing the risk of SSI independent of the type of surgery. So it's a conditional strength recommendation. The evidence quality was moderate. And I want you to look at the amount of evidence they considered to get to that recommendation. The reason they specifically said independent of the type of surgery, whereas in the ACS-SIS they said clean contaminated abdominal cases, and the CDC was kind of silent on the type of surgery, they just said consider the use of these sutures for the prevention of SSI, is because in the WHO's process, not only did they do the meta-analytic technique, they did an additional technique called meta-regression. And they actually analyzed all the data, not only for triclosan-coated sutures, but in other therapies as well. But they looked at the effect of triclosan-coated sutures relative to surgery type and wound type and even suture type. So there's a base polymer, that's coated with triclosan that can be different. They meta-regressed. They did a meta-regression analysis across all those factors, and they found no change in the effect. So they were very intentional in saying independent of the type of surgery. And the WHO ACS-SIS, they talk about clean and clean-contaminated abdominal cases because that's where the bulk of the evidence was that they looked at. And in the CDC, while they did meta-analysis, they didn't drill down on the meta-regression. So just a little bit of kind of behind the curtains as to why certain recommendations for a particular practice might be worded differently. We really have to think about what was their process and what type of analysis did they get to support their wording. So that's where I really encourage you to dig into the additional data that's available for all of these guidelines. And with that, I think we're at a good stopping point and allowing time for questions if we have them. I'd like to thank you for joining us today and hope this has been a beneficial conversation or the start of a conversation for many of you. So thank you very much.
Thank you. Ladies and gentlemen, your question and answer session will now begin. If you would like to ask a question, please key star then 1 on your telephone. Alternatively, you may submit a question on the WebEx, and to do this, click on the Q&A tab indicated by the question mark sign, type your question and click send to all panelists. So for an audio question, it's star then 1 on your telephone or type your question into the WebEx. Thank you. You have several questions on the WebEx asking if the slide deck and presentation will be available after this webinar. So
I'm going to defer to Sarah on that one. Sarah, is this something that we're making available or posting?
So thank you for the question. Yes, this will be available. Please contact your local Ethicon representative, and they should have access to the slides after the presentation.
Thank you. And there is a question of Sue McGann, and the question is, has anyone completed a crosswalk of these 3 guidelines?
So not to my awareness. You know, I've kind of started, you know, my own informal. I'm not quite sure what you might mean by crosswalk, but for example, I'm building an Excel spreadsheet where I'm like listing all the recommendations and the evidence behind them just for my own, you know, edification and interest. But I don't think anyone's done a full comparison or analysis of the 3 guidelines, because at least 2 of them came, well, they all kind of came out fairly contemporaneously, building in the delays, you know, with peer-reviewed publication. So all these 3 groups were kind of working in parallel, and what you'll see is if you dig into the data, they were looking at the same data because they were doing systematic literature reviews for what's available and kind of coming to very similar conclusions, as I said, with some difference in specificity of the wording based on the robustness of their analysis and how they crunched the data, or whether they, you know, ACS in fact did not crunch the data, they just kind of did a narrative review. CDC and WHO definitely did a lot of sophisticated data crunching, and I would say that the WHO probably looked at more recent data beyond 2014, because the CDC's literature search stopped in 2014. So the WHO is probably the most robust in terms of the amount of data that they considered, as well as the ways in which they analyzed the data, if that makes any sense.
Thank you. And you had a comment from Robin Neal, who said that this is an excellent review of latest guidelines. And from Arikar D'Souza, did the guidelines state that the use of triclosan sutures prevented superficial SSIs over SSIs of other depths?
So there were, again, if you go on to the, particularly the WHO and the CDC and their additional content that's available online, you can see that there were some analyses done to look at superficial versus deep incisional SSI and organ space SSI. One of the conflicting or the complicating aspects of that, there are 2, that some of the individual randomized controlled trials that were meta-analyzed didn't always report the breakout of the surgical site infection as superficial or deep or organ space. I can tell you that, so that's a difficult analysis to do when there's a lack of reporting. And there is some clinical discussion among surgeons, because we tend to interface with a lot of surgeons at Ethicon, both our internal medical affairs surgeons as well as our key opinion leaders and customers. There tends to be a fair amount of controversy about superficial versus deep, or deep versus organ space infections to begin with. So while there was some analysis that CDC did where they tried to break out the data and look at all SSI versus the different depths, one of the hallmarks of meta-analysis is that it's powered by a high N, and once you start breaking it down into those categories, then you lose the power. So in some cases, that type of analysis wasn't done. I can tell you there are individual RCTs that did look at superficial, but across the whole population of RCTs around these sutures, and there's 24 plus RCTs, I believe, at this point, that wasn't always reported. So there was an attempt to do that, but I think with the WHO, they did meta-regression against as many variables as they were able to. As I mentioned, you know, wound classification, suture type, and procedure type, and they didn't see any differences.
Thank you. There are several other questions waiting. Your next one is for ABX prophylaxis within 1 hour or 2 hours. Does this mean within the time frame or completed 1 or 2 hours prior to incision? Example, ABX started at 8:45 for an incision of 9. Is this compliance?
I think that's a great question. I think it's a little hard to answer because if you read just literally within 1 hour, it would say, well, you were within 1 hour because you were 15 minutes ahead. I think it was actually, I can't remember which one, ACS might have actually been more verbose about this, about saying, well, you really need to consider the agent and how long it takes to reach, you know, the target concentration in the tissue. So I don't think that's just a kind of a black or white statement. I think there's some modifiers to that. So again, a great thing to discuss maybe at your facility and how you best, implement that. But, and again, I might dig into the specific meta-analyses on that point. I think if you remember, WHO really didn't get into the timing. They just said do it and don't continue after surgical wound closure. But as far as the timing, I think that's there's some mitigating factors to that. So I'm sorry I can't answer that more specifically, but I think it's a great question, and it's one that maybe some of the additional content online will help address.
Thank you. Your next question comes from Jennifer Folds. You had mentioned not to be used with advanced wound dressings. How do these recommendations affect advanced wound dressings, such as Dermabond Pinot dressing?
Okay, so great question. Again, what the guidelines were saying was that of the available literature, they haven't seen a preponderance of evidence that a post-operative wound dressing or advanced wound dressing, meaning something, typically advanced wound dressing means not gauze. So it means a hydrocolloid or a transparent film dressing, or maybe a silver containing dressing, et cetera. Those tend to be very popular. One point, and I'm a little confused by the wording of the question, Dermabond Pinot is not an advanced wound dressing. Dermabond Pinot is a wound closure device. Now, so it takes the place of sutures or staples for skin closure of surgical incisions. So it's not an advanced wound dressing. And where the confusion might be coming is that it kind of eliminates the need for an advanced wound dressing because it's providing a polymerized cyanoacrylate film over the incision such that you really don't need a dressing, although our IFU says you can use one if you want to, but it's not necessary. So the recommendations really didn't get into type of closure other than to talk about the triclosan-coated sutures as a method of closure, because those are actively antimicrobial, but they didn't really get into discussion of topical skin adhesives or methods of topical skin closure.
Thank you. Your next question comes from Evan. It seems muprician versus nasal Providon iodine is not mentioned, while many facilities are switching to nasal Providine iodine. Sorry, any thoughts?
Yeah, so I guess, again, from an evidence-based perspective, and if we drill down to those individual studies that resulted in that strong recommendation for 2% nasal mupirocin for known carriers of Staph aureus, those would be based on predominantly randomized controlled trials, and I can't speak to knowing at this point the exact comparators, but I would perhaps guess that in some cases the comparator might have been nasal povidone iodine, or if there's a move towards nasal povidone, I would ask to see the studies that support that, and maybe some of those were published so recently as to not be included in this, or maybe they were included. So I apologize for not being immediately familiar with the specific data that led to that recommendation. But again, that's where either in the WHO guideline itself or in the online content, we would be able to easily kind of look at, well, what was the evidence that led to that recommendation, and did any of that evidence actually look at a comparison between the therapy that you're mentioning versus the recommended therapy of mupirocin. So that's where I think the beauty of the transparency of the WHO research is really beneficial to all of us that are trying to drill down and implement some of these practices as best we can. One just side note that I'll mention is that for the WHO guideline, they also have a whole section where they talk about implementation, and they speak to their plan to come out with implementation tools, because they realize that a guideline is only as good as its implementation. I talked about downloading this 186-page document, and if you just download it and put it on a shelf, it's not helping you. And oftentimes the biggest issues are how you implement this in your individual facility. So they talk about, they have a section on implementation. They have been very transparent in their methodology, so you can kind of take a look at it and implement it as best you are able in your facility with the resources that are available to you. So I would definitely encourage you to go online and pull down the systematic review on that particular and meta-analysis on that particular recommendation because that's possible to do.
Thank you. Your next question is anything new in the literature regarding infection prevention in breast surgery, specifically with expanders, implants such as S-ORA screening?
You know, I'm not immediately familiar with that, and you know, the only procedure they called out specifically in any of the guidelines was C-section. So, you know, I'd have to go to the literature and look at that, but I'm not aware of anything off the top of my head. I apologize.
Thank you. And the next question may be similar. Any tricholicin studies that include breast surgery?
Yes, there are a number of the individual randomized control trials of the tricholicin-coated sutures and breast procedures.
Thank you. And the next question is, are there any recommendations regarding post-operative nursing care of surgical incisions once the initial surgical dressing is removed?
No, and that's something that none of the guidelines, you know, talked about any particular, you know, like I said, with ACS, they looked at post-operative wound care and said, hey, we didn't find enough evidence to say anything. There were other recommendations that said that advanced wound dressings, you know, were not, hadn't yet reached a level of, you know, proof, I guess. Having said that, though, there are a lot of things that we tend to do in practice that maybe haven't reached an evidence base, you know, to be considered in this type of robust procedure. But as far as, you know, particular recommendations regarding post-operative nursing care of surgical incisions, yeah, there's nothing out there in the guidelines. In fact, to the contrary, they're saying it doesn't really matter. Now, in your particular experience, you may feel that it does. You may feel that it matters in certain subpopulations of patients, and that's where I think it's incumbent upon all of us to seek to publish our observations so that it can reach the level of being considered in an evidence-based guideline like this. But again, off the top of my head, I'm not aware of any specific recommendations.
Thank you. And the last question that's waiting at the moment is from Logan. And the question is there documentation to support CHG bathing for inpatients post-op?
I have not seen, most of the data I've seen on CHG bathing is pre-op. I have not seen a lot of post-op.
Thank you. And there are no further questions waiting. Sarah, do you have any further questions to submit?
No, we sure do not. Thank you very much, Dr. Ovington.
You're very welcome. It's a pleasure to be here today.
Thank you all for joining. Appreciate your time. Have a wonderful rest of the week.
Thank you. Ladies and gentlemen, that concludes your conference call for today, and you may now disconnect. Thank you for joining, and have a very good day.